We good? All right. Well, good afternoon, people in the audience, commission members, and anybody watching on the live stream. Welcome to the first meeting of this iteration of the Indiana Behavioral Health Commission. My name is Jay Chaudhry. I'm the Director of the Division of Mental Health and Addiction, as well as have the honor of chairing the commission last time and being reappointed by Governor Holcomb as chair this time. So really excited about our mission. It's an important one. It's one that I think it's a hard one as well. I think we have to tackle a lot in a short period of time, and we'll kind of go into some of those details. And so today's meeting is what I just sort of characterize as sort of a soft open here. We're just kind of like meeting each other, talking about our plans and goals for the work, working out tech issues, which we have not fully worked out. And we will before we dive into some of the meat of our work. And then, kind of talking about like how we plan to do the work. And so future meetings will not be this low key, probably. We'll probably be a little bit more heavy with kind of guests and more substantive conversations. But today we just kind of wanted to get started with our work. So I thought we'd start with introductions, and so go around the room and introduce yourself as a commission member and, just talk about, why you're here, talk about your why, and kind of what you hope to accomplish in the next year or so with our work. So we'll start very fittingly with Senator Kreider.
Well, thanks, Jay, and thanks to all the members who are participating. It's been my honor for the last 11 sessions to represent Senate District 28 in the state Senate, and during that time, I've tried to work on many issues around the provision of mental health services in the state, access to care, and each session, it was kind of the rhythm of my preparation for the session to have a discussion with various stakeholders, Steve and Zoe, and state agencies that are involved in work in this space, and try to determine what the next steps might look like, and then file bills related to that. And so over the years, I think I've worked on just about every piece, either whether it started in the House or Senate, of bills related to mental health services. And in the 2019 session, that meeting, it was recommended that we try to reinstitute the Behavioral Health Commission and take a deeper dive into system of care. And we did that. I passed that bill in 2020, and most of you know that right immediately following that session, we ended up in the heart of COVID. And so I think I and many other folks were kind of wondering, okay, what's this going to produce? And as luck would have it, I was assigned at that time to co-chair the Legislative Continuity Committee, which would decide how we were even going to conduct the next legislative session, which was the never-ending job that I hope I never have to do again. We literally were walking around with rulers and measuring distance between desks, and ultimately landed, as you probably recall, on the House doing their business on this side. And so that meant that I was occupied with that. I could not be the appointee to the Behavioral Health Commission that I had created. And so I watched closely and paid attention, and I was very impressed with the work product in the fall of 22 that came out, which gave me the kind of the direction to move towards Senate Bill 1, and filed that bill and passed that bill. And as we discussed what the next steps might be, one of the things that I wanted to do was continue the Behavioral Health Commission. And our leadership said, we understand that you want to continue it, but we don't need a 24-person or 26-person commission going forward. We kind of settled on what we believe the system of care should look like. And they allowed me to continue the Behavioral Health Commission with the targeted goals of discussing adolescents and senior citizens. And so it's a heavy lift. I think all of you realize that we are not at the end of this discussion. We're kind of really kicking off a more intense discussion. And I intend in the next budget session to be back with the next ask to try to more fully fund what we feel like is the actual need across the state. The initial work is really promising and I'm very hopeful that when I come back to the next budget session, I'm going to have reams of data that will support the fact that we are moving in the right direction, and that we will again have a chance to have that deeper discussion. So I'm very much appreciative of the fact that I get to be part of the commission now going forward, but also that you folks have agreed to accept the responsibility of representing your particular piece of this discussion. So glad to be with you. Thank you.
All right, thank you, Senator Kreider. And just, before we move on to Zoe, just thank you so much for your leadership and advocacy for this work.
Can you hear me okay? We're sharing a mic. Okay. So my name is Zoe Franz, and I'm the president and CEO of the Indiana Council of Community Mental Health Centers. What that means is I have the esteemed honor of representing all 24 community mental health centers in our state on statewide and federal policy. So, but my why, to answer Jay's question, is I've been a lifelong advocate for mental health and substance use, really due to a very personal reason of a loved one and trying to get that loved one help and not having the appropriate resources, even while growing up in the behavioral health system professionally. And so that why I was able to get that loved one help due to a policy change that took place a number of years ago. And so that really fueled my fire to know that policy is really where change can happen. And since then, really seeing the impact of what our community mental health system does. I've been to all 24 of them in the past 2 years. Just last Wednesday was 2 years in this role. And so when we do that through a variety of relationships with really all of you around this table. And so how can we support and enhance that safety net to be able to provide those services to the severely mentally ill, as well as those with mental health issues and substance use. So that is my why, and I'll pass it on to David.
Thank you, Zoe. So good afternoon. I'm David Reed. I'm the Deputy Director of Child Welfare Services for the Department of Child Services. My why is, we all care about kids, right? And the department certainly wants to make sure all of our kids across the state grow up healthy and prepared to be adults who could contribute to our society when they have their own families. We struggle with kids who've experienced trauma and have significant mental health issues that really need to have a lot of supports built around them to ensure that they can grow up to be healthy adults. And so it's really, really important work. And I'm thrilled to be part of the Behavioral Health Commission. Thank you.
All right, and Representative Garcia Wilburn, I'm just asking, introduce yourself and sort of explain your why you're here.
Sure. Hello, everybody. Sorry for my tardiness. I'm still juggling 2 positions. In addition to being at the State House, I'm also at IU School of Health and Human Sciences. And that's really where I was introduced to the recovery world. I've done a number of research projects with Overdose Lifeline and Hope Academy Recovery High School. And now there's faces and stories to addiction. And these are people that I've grown to love and care for, and they come from good families and they have great faith, and they're, middle class and above. I think we tend to think that addiction only affects a small few. Actually, it affects a lot of people. And so I've been on a pursuit to kind of understand that world more and improve accesses more. I also have a personal connection to policing and mental health. And that's really what brought me to office, is like Zoe, wanting to make change and understanding where that change needs to be made. And so I'm the wife of a person in long-term recovery from PTSD.
I'm Kelly Streeter. My position currently is the incoming president of the Indiana County Commissioners. We represent all 92 counties. We have an overwhelmingly amount of commissioners involved on our board whom have asked for my representation to be here, and I'm very proud to. I'm also the president of the Knox County Commissioners, and my why is mostly because I have been a voice for public health and mental health at my board table. But it's a little deeper than that. My experiences also include, I'm on the board of governors at Good Samaritan Hospital. I've sat there for almost 8 years, a vast amount of experience having a CMHC of our own and representing other counties. I'm also a patient of that CMHC, so I have that experience. And in my second job, I am the administrator of a county health department where I see all phases of mental health on a daily basis. So very happy to be here, and I look forward to the future.
Good afternoon. My name is Jason Thompson with AARP Indiana. I'm the communications director there. And with regards to the why, I think it's the importance of looking specifically at older adults. And thank you, Senator Kreider, for ensuring that they were a part of this discussion, because I think often older adults may be less recognized in this space as folks that may need assistance, whether that be the stigma around it and their unwillingness to come forward, or whether it's just access to whatever help and services they may need, because the aging population is navigating a lot of challenges in their life, whether that just be an adjustment to who they're living with, where they're living, just things in general that come with getting older. So I think it's important that we're here today to be a part of that discussion and have older adults be kind of at the forefront. So I appreciate the opportunity to be here.
Hello. Can you hear me okay? I'm Rachel Yoder. I'm a child and adolescent psychiatrist. I work mostly at Riley outpatient, and then through Indiana University and IU Health. I wear a couple of hats in that role. So I see patients clinically, mostly child and adolescents, but I also have a clinic where I see adults or parents alongside their kids, thinking about things from a family perspective. I think a little bit about the workforce, and that I am the director for the triple board residency program that combines peds, child psychiatry, and adult psychiatry, and the child and adolescent psychiatry fellowship. And I'm really proud of also the work. I co-direct the Indiana Behavioral Health Access Program for youth. And so that's our statewide program where any primary care provider can call in and talk to a child psychiatrist. We were super excited to be able to expand that to adult psychiatry recently too. So I think in that role, I see my patients, they come from, even though I'm based in Indiana or Indianapolis, they come through from the entire state because they're having trouble finding anybody closer to them than me. And then I hear from the phone call-in line, hear from these primary care providers who are struggling and with the severe patients they're seeing and where they need help. So just excited about the work that's been done so far and what we can build on.
Hi there, I'm Michelle Clark, and I am the Director of Student School Family Engagement at the Department of Education. So I'm here on behalf of Dr. Jenner and just education. I have been a school counselor, so I was a teacher and a school counselor for about 15, I always forget how many years it was before I came to the department, but I'm 21 years in education. And during the pandemic, I went back to get my licensed mental health certification because I recognize that the needs of our students are greater than my school counseling license could provide. But my why is really that I am a sister of an addict and someone who struggles with mental health challenges. So this work has always been a passion for me.
Great. I'm Steve McCaffrey. I am the president and CEO of Mental Health America of Indiana, and I have been doing this work for a number of years. And I can say that, and a lot of what I do is legislative advocacy. And we at one point had a mental health commission, and I can say, and I was appointed to that. And during that time, some of the most important legislation we had in those days came from that commission. And then when that commission expired, many of us worked on many bills that were helpful, but I don't know if they had the same comprehensive look that we did when we had the Mental Health Commission. And then when Senator Kreider had a bill to create the Behavioral Health Commission, I was very excited because I thought it would do a lot of the same things that we did with the Mental Health Commission. And it did. And the work that came out of that commission, you know, I feel honored to be part of that. I was very supportive of the bill, his bill to continue the commission, and look forward to working with all of you.
All right, thanks, everybody. You can see we have, I think, a great group here who offer a lot of valuable perspectives. I also have to, and they're gonna be embarrassed by this, but I have to call out my staff over there hiding in the corner there. They're not all the DMHA staff that are working on this, but I think, you know, Gina Woodward, Danica, Kate, and Bethany went and ran to print these slides, which is kind of filibustering a little bit while she runs to get the slides, but you know, really, really important. I wanted to highlight Gina in particular. Gina is our director of behavioral health workforce. And as we know, workforce is kind of the, you know, the main challenge that we all face, no matter what field you're in, no matter what specialty you're in. As Dr. Yoder mentioned, you know, workforce is kind of paramount. And so we're excited to have Gina help us kind of along the way to help us make sure we're all rowing in the same direction with that work. So I did not filibuster long enough, but Bethany should be here any minute with the slides. But we weren't able to display them. That was the tech issue I was referencing earlier. But we'll just go ahead and get started and dive into Representative Garcia Wilburn as well. I should mention your presence reminds me that we actually have two other legislative members, Senator Andrea Hunley and Representative Ledbetter. Their absence here is 100% my fault because there were some wires crossed. I don't know where between the appointments and the them getting to us, and I think it was on our end. So I apologize to you all. You know, good thing today is somewhat of a introductory meeting because we look forward to having full participation later. But we're really excited to have our legislative folks here, and I think I have filibustered successfully. So Bethany, if you can. Thank you so much. This is Bethany Eckler. She is in charge of our school-based programs at DMHA, and she'll be a key subject matter expert as well for all of us. I'm good.
Thank you.
All right. So our agenda today essentially is introductions and then coming up with sort of a plan to do our work more than anything else. Because we have as Senator Kreider and a few people mentioned, we have a huge, even though our scope is narrow, our challenge is immense, right? Even though it's somewhat of a narrow scope. So we, should talk a little bit about how we do the work and maybe reflect on last time as well. And so even though we've talked about this kind of individually, I thought it's helpful as a group to talk about kind of what our explicit statutory charge is, because that's gonna be the baseline of our work, right? And so we basically have to do four things. As an absolute bottom line, first of all, we should mention that our final product is a report that is due October 1st of 2024. So the clock is ticking a little bit. So there's kind of no time to waste. And that report has to contain at a bare minimum, I would say four things. I'm combining 1 and 2 here as in kind of one thing, but that's number one is sort of progress on the work that's already been started. So we have our crisis response system, we have our certified community behavioral health clinic model transition, and we have some other recommendations that were made by the commission last time. And so we have to report out on the progress of that work. And so that's number one. And then we have to do, as Senator Kreider alluded to, an in-depth examination of 3 special population groups. The mental health of youth and adolescents, the mental health of older adults, which are defined as individuals 55 years of age or older, and the level of mental health care available to individuals with intellectual and developmental disabilities. And so these are, I think really broad. Each of these could probably be commissioned by itself, to be honest. Like let's every single task we have could probably be like an entire commission. Are there any comments or questions on kind of just our statutory mandate before we dive into the rest? And then the next slide, we don't have to go into, but that's kind of the absolute bottom line baseline of the data that we're required to submit and analyze. We have retained the services of the Ursay Institute at IU to help us with this. And so we look forward to working closely with them. We're hopeful we can have a commission meeting at the Institute in Bloomington later this year. So. All right, this is my favorite slide. The reason I had a slide deck really was basically to share this slide. Because for people that can't see it, this is our goal, and there's a picture of the first poster of The Empire Strikes Back. It's not because we're evil. It's not because we're gonna, take over the world or anything. It's because Star Wars was a groundbreaking movie. Changed the cinema, changed all this before. The Empire Strikes Back, its sequel, is sort of broadly thought of as being far superior in every single way, right? So if the first commission report was Star Wars, we want to generate The Empire Strikes Back. Okay, so that's our goal, broadly speaking, is we want to do this better in every single way. In order to do that, I thought we could spend some time reflecting on the first commission report. And I just have a few thoughts, but I'm happy to open it up to, anybody. We have Zoe, Steve, and I were on the commission last time. Sarah Kreider obviously was very involved. And so I'll just reflect. I think the thing we did the best, and this is something I'd love to build upon with our work this time, is I think we had a simple message that was pretty easy to understand. It's really easy if you read other similar commission reports from other places, or other subject areas. It gets really lost and kind of bogged down in like all of the 100 different things that you could do to fix this or make this better. And I think we did a really good job last time of like just picking and choosing and sort of saying, this is what we want. We want to build an infrastructure. Okay, what does that mean? It means these two things. And that's what became Senate Bill 1, right? And I thought that was probably the best thing we did, and the reason that we were able to get Senate Bill 1 and get the buy-in of the General Assembly. So I don't know, Steve, Zoe, if you want to add on anything you think we did well that we want to continue this time, or anybody else.
For me, what we did well was collaboration and bringing everybody together to really be, I think, Jay, you said, under the same tent, and make sure that we had that support to be able to get Senate Bill 1. I will never forget when Senator Kreider, messaged me that I got Senate Bill 1 on a mental health bill. And again, as a lifelong advocate, to have a number one priority in the Senate to elevate mental health to that level was really a huge accomplishment. And I just really thank you for your leadership in that, as well as the commission that was really under the tent with you to really drive that.
Yeah, I totally obviously would agree with that. And I think, Jay, I totally agree with your point. And we struggled with that, if you recall. So we had with the first commission, we had a number of meetings. We went down a bunch of rabbit holes. And I don't say that as negatively as it sounds, because it was almost like time had passed. We hadn't done much in terms of the mental health delivery system. And so things had built up. And it was almost, we were vomiting all the things that need to happen. So when you say we focused on the key points, and you could have all the 100 things, we did have the 100 things. We just decided that we want to market it as one or two things. And so I guess a reflection I would have is, what do we do with the 100 things? Do we just let them drop and say, oh, we're just going to focus on these two things? Or are we going to revisit? Because we had committees and there was a lot of hard work and it was all good stuff. Some of which requires legislation, not all, but as a person who's fought for these things for a long time, it's like it was almost a directory of all the things Indiana needs to do and hasn't done. And I'm not sure how you do 100 more things, but I wish there was a way we could do that.
Yeah, and probably just to add to that, the piece, and I think, Jay, we talked about this in our individual behavioral Health Commission when we did the check-in. It's the sustainability part and really elevating the gaps within. And so as Senator Kreider has said, as I've said, we haven't done our victory lap until that sustainable piece is there. And as you guys know, we really lifted up the surcharge for cell phones, and that did not end up at the end of the budget session. So what is that next ask come the budget? What can we all get behind? We've had several conversations on what that looks like, but I think this group really making a recommendation and being under the same tent on that would be really helpful in that next budget period.
Of course.
And so the representative understands this well. But as a legislator, the thing that you want is a simple message. And if you want to kill a bill, you start to create confusion around the bill. And people that are looking for an opportunity to jump off can jump off pretty easily. And so when they came back with the 3-prong recommendation, it's a place to call, someone to respond, and a safe place to go for care, that's an easy message. And then I'm getting ready to go into my 12th session. I have never had a bill or seen a bill really where it was not a question really whether it was going to pass or not. It was more how much in the financial aspect are we going to end up with? And literally people are coming to me daily saying, add my name to the bill, add my name to the bill. In the House, when it got to the House, after the first hearing, there were more co-sponsors on the bill than it's needed to pass the bill. So it was, when you get past 50, you think I'm in pretty good shape here, right? But that consistent messaging, and then the way the commission and the members on the commission pulled in the faith community and the business community, and that really I think a key part of that was a study quantifying the cost of untreated mental illness. And it opened so many eyes at a time when most people had come through COVID impacted personally, either through anxiety or, whatever however you describe that. And I think there was some timing involved in things, but the way you get a bill as Senate Bill 1 is because you have been on message for more than one session. And so I think we have an opportunity here to come back with a report that people recognize the quality of work that was done in the last commission report. And frankly, we're going to go in next time with even more credibility based on the work that was done. And I know I was not part of that discussion, and I've been in part of some of those meetings where everybody wants to go down their version of a rabbit hole, and it can be painful, but the final report, I think, speaks for itself. And so I'm looking forward to kind of the same opportunity going forward.
Sure.
I thought you were trying.
Well,
You
no,
don't have
but
to say anything. If you want to,
actually-
you can, but yeah.
Sure, I'd love to comment just as first as an observer. And I think that's key because, you all were on the team, right? And I was in the stands. And so I think what it felt like to the community, and I collectively say this for all of us on this side of the table, was a sigh of relief that we finally were understanding this in Indiana. And I think that's huge when it comes to messaging that, we are now getting up to speed where we have felt desperate for so long. And I think the more that we can create that unity through the messaging that this affects everybody, that everybody will deal with this in their lifetime if you haven't already, the more that we can make that messaging soft for everybody's appetite. So I just want to say thank you for the work that's already been done, because I think we do have an opportunity to be a part of the resistance.
Absolutely. Yeah. Yeah, absolutely. Well done. Yeah. And I think to that point, and this is one thing, kind of going into the second part of this opportunities for improvement as well. I think one thing we didn't do, and this actually may have been a blessing in disguise when it was happening, because this was still a public health emergency. Everything was streamed. There was not a single in-person meeting except for the last one, right, of the entire commission. Last time, which I think was a blessing and a curse. We had probably way too many meetings because it's easier to get a Zoom meeting together, but also I think we went down some rabbit holes for that same reason. But I think to your point about generating that drumbeat of support, right? I think we waited, and we almost had to wait until the report came out and then we started. And I'm thinking this time we need to figure out a way to, like, even though we'll be doing the work and still coming up with the recommendations, like, what do we do over the next 6 to 8 months, before the report even comes out, to kind of keep this on people's radar, keep that conversation going. And there's different conversations to be had about that, but I don't know if people have thoughts on that, because I think that this time, I don't think we're going to fly under the radar, and I think we should take advantage of that in a different way. Everybody agrees. Okay, cool.
Do you have thoughts about how to do that?
Well, I don't know. I'm opening it up here. I mean, we don't have to solve it right now, but it's just in general, I think, like, part of what I was thinking, and so this goes to the opportunities for improvement. I mean, one thing we didn't have at all last time, and this is very contrary. It's like my core feelings about this. But one thing we didn't have at all last time was any degree of public involvement. Like, we didn't have a single person that was not invited by us or by me as the chair to come testify at the hearing. And part of that was, I think, just, again, this was public health emergency, height of COVID, like, all online. But it's a double-edged sword, right? Because I think if we want to be targeted and simple, we've all seen Parks and Rec, we've all seen, how things go when you invite the public in, but this is also really important to have their voice here. And I think will be important to the point of building that critical mass and building that drumbeat. And so any thoughts on how we can generate public involvement, but without letting it kind of, like, take over or dominate?
So when we had the mental health commission, to your point, we did have field hearings, and we would have them at locations that were relevant to what we were focused on. And so sometimes we'd have it at a provider, sometime at a hospital, sometime at DOC. We had it at a clubhouse one time. And then the press would come locally, and the local legislators would come as well. We'd invite them, of course. And sometimes they would want to testify because they have something to say, and, they want to get some media themselves. I think I like this idea. I hadn't honestly thought about it, but when you've got a big hit movie coming out, they do those little, I'm going with your Star Wars thing. They'll do like 30-second things, and then they'll, like, every 3 months, there'll be a different one or whatever. I think that's a good idea.
Yeah, like teasers.
Yeah.
So I get invited to a mental health symposium about weekly, it seems like. I can't make all of them, and I started this practice of filming a little welcome vignette kind of thing to send welcome to the Mental Health Summit, appreciate your work kind of thing. But it seems like there's opportunity there to message what's happening and to encourage folks who may have some specific thing that they think is valuable to the commission for consideration to present that, because oftentimes I think people have really good ideas. This morning I met with college students from Valparaiso, which threw out the idea of providing mental health services at public libraries with a seclusion room where you could go and sit, and people who don't have access to a computer or internet access and things like that. And pretty well thought out presentation that they had. And so I think there are so many people that are looking at ways to be helpful, but they don't really know, like, how to be helpful or who to talk to in order to be helpful. And some of those summits, I mean, you get so many people with different areas of interest, and this is one of those topics I often say where it takes a village. And perspective from the county health department may be different than the county hospitals or somebody else in the community. And so providing that, at least being open to receiving input, I think is something that's really valuable.
Absolutely. And I think when we get to our kind of work plan, proposed work plan, you'll see, I think that it's built in such a way that we can kind of accommodate that for sure. The other thing specifically, and then I'll open it up for other people too, because I think that just again, to your point, Representative Wilburn, about not being on the inside versus the outside. But one thing I think, and Kelly, I'm gonna put you on the spot here in a second here. One thing I think we did not do very well, partly because we just didn't have the information at the time. I think we will have it this time, is we didn't get very specific about our financial kind of recommendations. We did, I mean, we had some projections and some estimates and some kind of baseline from other states. But the number we came up with, I think, was exactly that. It was a projection. It was an estimate. It was not, I think, detailed enough in a way, and that came up during session a few times in these conversations. It's like, well, these are all projections. And I think part of the answer to that is, well, they kind of have to be, because we've never done this before. But I do think that there's an opportunity, and Kelly, I'll let you kind of chime in on this one. From your perspective, like, how can we and how do we get more specific with our kind of financial recommendation?
I think learning what I've learned just in the last few months of the processes of the commission and coming up to speed, it's understandable, the three-prong approach. We have to start somewhere, and getting the biggest bang for our buck makes sense. But from a county perspective, I think, a lot of times this kind of gets lost in transition, but everything happens local. And even regionally, we see clusters of the same types of issues. So I think seeing data more specific to regions and counties and taking it this next step further with this commission, I think had it happened last, would it have been effective? Probably not. But I think the ability for us as counties to see that grow with more specific, not so much rabbit hole, but the time being able to put in for that opportunity. That's why I call this exciting. So to follow up it from our perspective, the more data specific for the regions is hopefully a goal.
Thoughts on that?
Well, I would say, as a member of the Appropriations Committee, I was pushed on quite a bit about, at the same time, we're seeing a large increase in our Medicaid spend. You're throwing out a program which is kind of nebulous as to how many people are going to take advantage, how much that's going to cost. And so I believe that 18 months or so of experience is going to be valuable in kind of seeing what that looks like, that expansion of services and things. At the same time, when I think of the finance part of this, I pushed on you guys, give me a more solid number, and folks in the room help provide that more solid number. And I gave that to everybody I could hand a piece of paper to, because I heard the same thing, there's several different versions of numbers floating around, and which one is it? And I would say it's this one, it's the last one. Look at this one. And so I'm part of this push and pull in the budget making process pretty constantly. I think my message became towards the end, look, we're probably not going to end up with some extra funding mechanism, but you have to understand that what is an expensive problem today becomes a much more expensive problem next year and the year after and the year after as this goes along. And so I intend to be back with looking for some additional dependable, predictable funding stream that will not rely on somebody like myself who cares about this being part of the discussion 10 years, 20 years downstream, and it becoming more of a forgotten type thing again. And so I'm really encouraged with some of the things I'm seeing happening, and you know, we're going to just continue to begin their digging.
Can I just, were you gonna say something?
Oh,
I was just gonna say, just for, put it on the table for discussion, I don't have an answer to this, but to your point about the Medicaid focus, you know, I attended the Medicaid Oversight Committee the other day, and there certainly is gonna be a pressure to hold the line on Medicaid expenses or even reduce them, and whether or not you think that's a good idea. As a concept, that is problematic from a mental health perspective. 60% of mental health expenses roughly are Medicaid. If we expand to CCBHCs, like we said we wanted to in Senate Bill Act 1 in the commission report, then it's even going to be a bigger number. And so somehow we need to be able to communicate that when, and I don't know how you do this, because people have there are personal and political opinions as it relates to Medicaid. But and so irrespective of what your position is, what we're talking about is math. And it's the way to figure out how to objectively increase mental health services in a way that costs the state less money than if they provided it themselves, and where there'd be a cost savings to other systems. And so somehow we need to have an economic analysis that is different than a social analysis.
Yeah, just one of our challenges will be that by October of 2024, a lot of this is going to be TBD, right? That's one thing I think that we just have to figure out a way to work our way around, because it's, you know, things don't, no offense to your colleagues either, but like things don't tend to work as quickly and sort of reverberate as quickly maybe as some folks would like there might be savings in 2027, but we're probably not going to see them, quite honestly, next state fiscal year, because this takes time to kind of work its way through the system. So it's going to be interesting kind of like exercise again in projection and in actuarial analysis and getting real-time data from your members, Zoe, that sort of thing, as sort of a bulwark almost against this force that's coming. The force, all right, I got that, this sort of you know, reduce Medicaid, which I think is probably going to be part of the conversation next budget session.
Well, and I think going back to what Kelly said, as far as the data and the outcomes, you know, on a local and regional level, it would be really beneficial, I think, for this group to come up. What are those outcomes we would like to see in our local communities? You know, for me, seeing jail recidivism, emergency rooms go down, suicide rates, overdose, you know, those are kind of the main things. But like, what outside of those outcomes would be helpful? You know, because when we say outcomes, what could we collectively get behind to define? Because those outcomes will also drive the financial implications going down as well. And then one other thing on the financial implications is really keeping in mind that Medicaid's just a piece of this braided funding. One thing that Indiana is super strong with is the braided funding to be able to support the mental health services. And you pull one thread of that braided funding all can go away. And so just being really aware of that. We will be doing an updated community mental health financial impact report this coming year, and I'll be able to share that as a resource for this group to help with that braided component.
I just really want to second Steve's remarks, because I see how a small shift in CMS affects hospitals definitively. And then if this goes down, then hospitals pay more for mental health and, add in recovery efforts, add in our jail corrections all together. So key component, Steve. That would be interesting to see how that balance is kept between all entities.
Thank you. I don't know if this is possible or realistic, but I think people were very taken by the IU cost study. And so I don't know if we could, to your point, Mike, build on that and say, okay, so we did this. And now a year out, based on the things we started doing in Sentinel Act 1, we're projecting this and build it out that way. So instead of it being a one-off, it's a consistent strategy.
Yeah, as I mentioned earlier, we do have the Ursa Institute kind of on retainer here. They're focused a little bit on more on like the outcomes, to Zoe's point, that we specifically have to work on, like report on, and but deeper than that, like more than just like, how many services were provided, but like what was the impact, a little bit more of like an ethnographic look at like how is this actually changing local communities. Like, so, they're going to be embedded with law enforcement, for example, for a couple of weeks to do like a report out on like, this is how this is changing the stress on law enforcement, the culture of law enforcement, that sort of thing. But I don't think it would be too difficult, and we can talk more about this as we go on. I mean, to maybe sort of add to that some sort of and we've had some initial conversations, like what exactly is, number one, I think when people talk about Medicaid spending, I don't think that it's in that, again, this is maybe naive of me, you can push back on this, Steve, especially, but like, I don't think they're thinking we need to reduce Medicaid by reducing mental health. Like, I think those are kind of two separate conversations in people's minds, even though that we know that they're related. So like, can we in a way almost be like, recognize and so show people like, if you care about this, and people do, you need to approach it a little bit differently. I don't know, but I think it's a good idea and something that we can talk to some more academic partners about. And Dr. Yoder, if you have people that we'd be able to tap into, look at you for sort of the school of medicine folks.
Seems possible, yeah.
Okay. It's a skill set that I don't possess, but people do.
Can I ask a point of clarification regarding the cost of mental health study? Was it the projection of at first diagnosis or an adult person's, course through the system?
It was sort of like, the goal was to get a global, as all encompassing number as possible. And so that was kind of everything. It was just published in JAMA. So it met their criteria, obviously. So I think it was fairly rigorous, in my understanding. But yeah.
Well, no, I only asked because, the adolescent, so I hear this a lot, and I know you feel this a lot, our lack of ability to retain our young people when they're in crisis in state has long-term impacts, right? And so that was the reason why I asked, because it would just be interesting now that we're diagnosing much sooner and parents are understanding the need for intensive treatment sooner. They're not often finding that in their home state.
Yeah, that's a great point. And so maybe like a little bit more of a granular dive into some of the specifics of that's a big issue. I mean, in general, the lack of residential access for children probably is something that has a quantifiable financial impact.
And truthfully, one of the priority areas.
Right.
I meet routinely with school administrators in my district, and the number of students who are so dysregulated that the learning environment is just like gone in the classroom for periods of time is a real challenge for them, and they're losing access to facilities like the Rise Learning Center and some of them that kind of specialize in that intervention for a period of time, and then the students able to go back into a traditional classroom. And so, I mean, to the point that some areas are trying to figure out ways to put together cooperatives to have, a place for the student to go for a period, and some systems have students even in other states. And so it's a challenge, but it's like I I try when I speak to groups to say, my observation when I worked at a hospital was whatever the statistics are, they completely underrepresent the overall impact of the mental health challenge, because if a person in a family is really struggling, the whole family is struggling. And depending on whether it's a school age person or it's a senior or who it is, you have so much opportunity for those statistics that were in that report of lost productivity and absenteeism and all the other things that impact the rest of the world, the business world, the education space. The message is that anything that we do that has a positive impact has a positive impact on a lot more people than the one person as well. And so it becomes like you mentioned, Jay, I don't think the discussion is how do we increase or decrease the Medicaid spend by taking away mental health services. I think more of the message is how do we make sure that what we're spending is in fact producing a positive result, which will positively impact a whole lot more people than just the person that we're treating.
I think that's such a great point. All well said. And I think recognizing it's going to be an investment.
Right.
Investments take time to pay off. And can we really be committed to the time it's going to take for us to really reap these rewards from these investments that are being made? That's not going to be by next session or even the session after that, probably. It's going to be generations. These are impacts for generations on families. And like you said, if we can help most of these adults that have mental problems, those problems started in childhood, right? And how do we respond then? How are the families supported to help that young person who will eventually become an adult? Either an adult who's working and contributing to our society or an adult who's not. And how we respond to families will determine the answer to that question. So we got to really, I think, go into the long haul.
Well, Michelle, I know you all are swimming in data, right? So some of that probably is relevant here too. So all of the different David DCS, like we probably have a lot of this data probably in house. You need to like have somebody to wrap their arms around it and put a number on it, which kind of explore that in the interim.
Well, and if there would be a way that we could raise the positive narrative up versus the negative narrative with this group, I think that would be really important. We hear the negative outcomes of things because that's what our job is, right? Is to hear those things often, but without a lot of the services in this room and without the psychiatrist that's in this room. I mean, we have a lot of success in Indiana as well. I hear that nationally when I'm out on the national landscape about Indiana and the things that we have done, such as in our peer recovery hubs, such as the program you did, with IU. Our community mental health system is unlike any other in a lot of the states. And so if we could raise a positive narrative, I think so much, just probably because of our current landscape, everyone focuses on the negative news when there's a lot of positive news. I think that we could really elevate.
I agree. Any other thoughts or reflections on kind of like globally what our job is, what'll help, what we did last time? We can dive into kind of the one actual agenda item, which is like voting on our work plan, but
Just one thing, considering when the last version of this commission took place, a whole pandemic thing happened. And so I think also from that perspective of how the fallout from after that with regards to social isolation, especially for older adults and the impact that that had on them as well, and the repercussions that have rolled forward from that, because that's not just because the pandemic is, over or doesn't mean that those issues have been resolved with a lot of individuals. So I think that that's something that is, I think it's also to take into account as we go forward in looking at some of these issues.
I think that's so well said too. I think it's also diagnostic, right? We know the isolation is bad for mental health. So how do we create for people relationships that are healthy and strong? It's a big part of our work. Otherwise, kids won't grow up be those healthy adults we talked about, so.
So this is where I completely agree with you, both of you, 100% from a personal standpoint, and this is something I think we can explore further in the subject areas, but like from a policy standpoint, that's where I kind of get like a little bit of like humility as the state is important here. Like, look, like there's a lot of things we can do and do well, and there are things that we do well, to your point, and that we should talk about them. I feel like it's very difficult for government to influence kind of like broader social trends. So like when we go forward with our work, and we'll talk about all these things for sure, we have to keep in mind that ultimately I think what we're producing is primarily a policy roadmap, right? Primarily about policy, primarily about funding. I mean, we can put in aspects of, you know, prescriptions for overall better society to a certain extent, but I think we also are producing when it comes to, you know, what are the mechanics of it? Like that really matters. Like and that's one thing I think, again, to what we did well last time was we had very clear mechanics, even though our finances were a little bit murky, but a very clear mechanism. Okay, we need to do this thing. But you're absolutely, I mean, those elements are really important. I think it's a good segue, because I think when we dive into our meetings, you know, the first meeting, if it's about older adults, I mean, I'm hoping that you'll bring a lot of folks that can talk specifically about, you know, not only the social isolation and the impact, but also on like some specific kind of policy prescriptions to help remedy it.
Hey, Jay, I do have one
of course.
request. I think a key component to a lot of things we talk about in the future is tracking how the CCBHC transition is going.
Yes,
So if that could be a regular part of,
it's going well.
well, that's good to hear.
Yeah, so we actually, we're explicit. So a couple of things, that's one of our explicit data points that we
Okay.
have to talk
Yes.
about. But we will also, I think, and I think Zoe can attest to this as well, we will have significantly more data available to us than we had at any point in the last however long specifically about that. And so we need to keep it front and center, absolutely. And so, you know, I think we can talk about that here in a second, maybe with the work plan, but you're absolutely right. That is
Future.
talking about what's already been done is a really important piece of this, and framing that probably as much in a positive way as possible is really important too, because I don't think your colleagues want to hear, well, we gave you all that money and it's not really having an impact, or it's not really having a positive impact. We need to be able to talk about this stuff positively, while also being aware that like there's still a lot of work to be done.
Yeah, and kind of along those lines, and what has also kind of been said, besides just the high level issue that is, you know, social isolation, especially with older adults, but also the local impact and the local work that's being done. Because I know that there's been good work with regards to mobile mental health units with regards to up in Gary, Indiana, and we've seen some really good progress in some smaller rural communities around mobile integrated health and some of those opportunities that are going to be there. So I think there are some avenues to have these kind of those discussions along with these potential solutions to some of these problems.
Yeah, and I'll have excellent news to report from the county level of how coalitions are forming, partnerships are happening amongst all of the entities as you named. So it's naturally moving already with investments in mental health and public health over these last few years. So yeah.
Yeah, I would say that one of the trends I've noticed, and I was just in Fishers talking to their crisis intervention team class. The public safety side has embraced this model significantly, and things like community-based paramedicine, where communities are using their paramedics to maybe go out and interact with folks that they got a call on slip and fall or something the day before or the week before. When they're not on a run, can you swing by and see Mary and see how she's doing, kind of thing. That system is being embraced because they're seeing such a positive feedback from the folks. And in fact, some healthcare systems are actually subsidizing a shift on fire departments, saying, you know, this is so valuable, we're going to use these folks to do our discharge checkups and things, rather than have the person be readmitted, which is a ding on the hospital system. And so Within the public safety community, which is a system I grew up in, I would say the folks have embraced this. They've realized that that individual, that they can get the health care, mental health care that they need, means that they probably won't deal with them again the same day or 2 days later. And so it's been a really positive thing, I think. And it's not just within one area of the state. It's everywhere I go, I hear that same message. And so many positive things happening. But each time you check a box, it seems like there's 3 more boxes that open up. And so I think that's my hope, and the work that we're doing. Are we beginning to stabilize a large enough area that we will notice where the vulnerabilities are? We're going to notice where we need to put some extra attention. And then, if you can keep that area stabilized, then you've got the time and resources to put to that next challenge. And so I told a group the other day, we didn't get here overnight. We're not getting out of here overnight. It's going to take a lot of time and attention, but I think the buy-in has been really pretty tremendous. And so I'm pleased with that part of it.
Yeah, I think we're talking about, storytelling, right? We have to thread a very sort of particular needle with storytelling. We have to lift up positive, sort of show that the previous investments are paying off, but not painting too rosy of a picture, and let folks think that we don't need a whole lot more work to do. And so that's going to be, I think, one of our probably biggest challenges, but also something I think, we have a comms professional here. I think we can lean on.
Love to meet him.
Lean on Jason here. I moonlight as a comms person, but I think my comms people don't like it. But I think it'll be I think it'll be a fun challenge. And I think, the nice thing is we do have some DMHA is going to put some resources towards this in terms of getting people to do some of these studies, getting people to produce the final report. And we have the firepower of the folks in this room, which I'm looking forward to. So other kind of more global thoughts No, go ahead.
Maybe it's more specific than global.
Very good.
Along those lines, like just hearing a little bit, I'm excited to hear about like the Ursay Institute and what, I wonder if there's a way we could see like the scope of work to kind of see what outcomes they're targeting, where we can fill in. And I think that could guide there, though it's not the big picture outcomes, there are probably some reasonable outcomes, even in a short-ish time period of, number of calls. And could we say, does this call represent someone who didn't have to be seen in an ED because they were given something else? I think just seeing the scope would be.
That's a great, absolutely. And I think some of that's still being worked out, but I think once it's ready, maybe at the next meeting, hopefully we can because I was thinking, and this is jumping to the work plan piece of it. I think even though we'll sort of have themes for all the meetings, I think the truth is we are up against a time crunch, and we're a small enough group where I think we should probably retain some flexibility in all our meetings. So will be elements of, the overall progress towards our report as part of each individual meeting. So that's actually not a bad idea for the first meeting. It's like, okay, maybe some more details about, and we'll have some more details by then about like what specific outcomes we're targeting. So then we'll know, to your point, where the gaps are, and maybe where are you, or somebody could help us fill it in. Because again, like while we have some resources, the state does not move fast. Shocker to anybody here. And so when it comes to kind of pivoting to do new things, like we're going to need to rely on our kind of nonprofit and other partners who maybe have a little bit more flexibility to do things. Because every single agreement I enter into at the state, you can count 6 months before I have like the actual ability to do anything. So
I just have one last observation,
yeah,
broad
go ahead. No, go ahead.
observation.
You're good.
Again, like sideline team, I think one thing that was done really well was like the public facing messaging regarding all of the changes coming down. And like to David and Jason, to your point about isolation, I kind of envision the commission, one of the takeaways being like another public education initiative, because loneliness doesn't just affect seniors. We're seeing a decrease in the amount of free play time that children are experiencing. So loneliness is being in front of your tablet all day. And when I'm in front of my tablet all day, I'm not practicing social referencing and I'm not conflict negotiating and I don't understand norms. And so when I go to school, of course, I'm an anxious mess because this is the first time I've been around somebody other than my device. And so I would love to see, because we normalized screens so much during COVID, I would love to see these more global public health approaches to engaging in positive, healthy relationships too, as a means to decrease mental health episodes, particularly among our youth and our seniors, because this isn't normal, but we have normalized it. So just kind of considerations, because I think the public messaging that went out the first time was, phenomenal. And can we replicate that to kind of a different public health approach to addressing mental and behavioral health issues?
Yeah, I love that. And I would sort of turn that back on everybody here to say, like, part of, you're here because of your experience, but you're also here because of your platform. Right. And so every single person in this room, I mean, some of our platforms are a little bit more constricted than others, just given our roles, but we all have platforms when it comes to messaging and when it comes to that public facing messaging. And I think that if we can get on the same page about that, that'll be remarkably powerful. And so, whether it's Riley or AARP or whoever who's sort of like saying like, the theme of this, yes, there are specific policy prescriptions that are contained within this document. However, the theme of this is, more, undoing the harm. We'll put it more poetically, but like undoing the harms of social isolation, or, we'll come up with some sort of tagline or something. But that I think is a really important piece of it. And I think maybe you just volunteered for the communications committee subcommittee just now.
I'll second that.
But absolutely. So as far as anything else, this is really great. So I don't want to stop.
I just wanted to go back to what Jason said. So being part of the last Behavioral Health Commission, it was my recommendation to have the elder population looked at. And really that was because of the work that the state is doing to move home services more home-based. And that I think that is a risk of increased isolation. And so on the policy side, Jay, going back to what you said, ensuring that as that transition is being made, that the social components that loved ones get within, an assisted living or within a nursing home, that there's some sort of sustainable plan that they're able to go to a clubhouse or some sort of community type function, and that it's not just the medical care and the treatment, but the social components of the aging population. And so that I think is where the policy tie can come in on helping some of that isolation. So I just wanted to put some closure as far as where that whole thought even came from the last commission.
Yeah, absolutely. Thank you, Zoe. Thanks for making that recommendation. Anything else? All right. So I've talked to most of you about this, I think already, but last time we had these subcommittees, and I think it was a useful exercise. It was kind of rabbit holey, but that's okay. But we were big, so that was part of it. We had 24 people on our commission, and trying to get a group of 24 people to do anything is really hard, right? It violates the the kind of Steve Jobs rule that what is it, two large pizzas and that's it. So like any big group bigger than that can be fed with two large pizzas is too big. I think we were way above that this time. Thankfully, we're smaller. Maybe we overcorrected, but that's okay. So rather than having subgroups, the thought is that we have sort of themed meetings throughout the year, and we focus on our areas while leaving kind of flexibility to have conversations about our bigger task. And just again, the work plan for people that can't see would be kind of older adults meeting is the only one that's scheduled. And so Jason's been working with Kate from our office on kind of some plans for that in January. But then we have the individuals with intellectual developmental disabilities, February, March-ish. Children would be in May. I'm thinking we might need, that's probably an all-day meeting, just to be honest. That's probably just from a prominence standpoint. They're not speaking about importance, but just from a prominent standpoint, probably our most prominent piece right now. The mental health of children is something that I think everybody's talking about. And I think those of us with children ourselves, I think are also kind of, seeing some of these things too. And then, so that would probably be May. That may need to be a whole day, may need to be 2 meetings. We'll kind of see how we're doing with that. The report on progress, I'm giving it the most time because that's going to take kind of like the most time to gather all of this data together and figure out a way to present it in a way that's the most easily digestible. So I put June for that. That may need to be bumped. And then a final meeting, just in order to give us time to have the report done, would need to be sort of early to mid-August, where we can kind of vote on the content of the final report and make it happen. And then sort of leaving us with some flexibility, and which we can talk about at each meeting. Do we need other meetings? Again, I know everybody here is super busy, and you're doing this as a volunteer. And so, we don't want to have too many meetings, but I think, if we want to be able to retain the flexibility to have additional meetings if we're needed. So any thoughts about the kind of, it's a rough work plan. I think it leaves us with flexibility to modify as needed, but will kind of hopefully keep us on track in terms of progressing towards our goal. Discussion on that. Can I have a motion to approve? Second. All right, all in favor?
Aye.
Nobody opposed? All right, so that is our work plan. Thank you. And with that, I think we'll open it up to any discussion for anybody on the commission or anybody in the audience who wants to weigh in.
I don't know if there's a email group or something's been created yet, but I'm certainly open to having, as members have some idea or some interaction, if you want to share that with the group so that we can kind of see maybe something leading up to the next meeting. I think that's beneficial. I'm perfectly open to Zoom calls. I think all of us have had Zoom calls outside of the regular meetings where something might need to be discussed, but the work I think is important enough that if you have some interaction that you think you'd like to bounce off of the doctor or something and say, hey, I had this come up. Can you help me understand what's happening here? I think that part of it's valuable as well.
Absolutely. So the one thing I think we do need to be cognizant of, and this is something that our legislative friends don't have this particular responsibility here, is that we are a public commission.
Okay.
And therefore kind of official commission business does need to be conducted in a manner that's open to the public, which means public notice as well as accessibility. Which is I think we all agree is a good thing, right? That the public can kind of see what's going on. That just means when we're kind of working collaboratively together, there's just a few kind of restrictions on like what we can do in terms of discussing the commission's business without having open to the public. Had to say that. So that's the truth of the matter. But that doesn't mean, and that's why we have our wonderful DMHA staff over there that's kind of why I brought them on board, because they are not commission members. And are kind of available and for any of us to help us do some of this work, kind of in the interim. And so if you have other people you want to kind of volunteer from your organizations as well, feel free. But that's going to be our kind of answer to the problem, not the problem, but the issue of public access wanting to do work. So the answer to your question is yes, we can create an email group for sure. And when it comes to meetings, we have to just make sure it complies with the public records.
With the IDD component, will we also have support from them since that really falls outside of
Yes.
the team? Okay, perfect.
Thoughts, we're going to call them final. All right, well, the first meeting is adjourned. Thank you to commission members, and we'll talk very soon. Thank you. Thank you. Yeah.
There would be
That was easier than the first commission, right?
Well, I don't know if all the things will be to see.
Like restricting access to social media accounts.
By design.
Somebody, right.
So I really think.
If you need anything, like, if you need a pass through.
Yeah. Yeah, pretty good. Somebody else is paying some of this too.
Okay.
It's been good. Not only- Yeah.
See you again.
Just, I think it's just a 5 years different.
Okay.
Yeah.
All right, I'll see you.
You know, they have you on. They're better. Great to see you.
Okay. Welcome. 27. That's, you're invited. You can stay in. Thanks. You too. Hey, we did next week, right? Well, that- Yeah. Yeah. I want to. Yeah. She has. Yeah. We do like it. Yeah.
Whatever you want.
Great.
Okay, you too.
I'm thinking about you. Seriously, I didn't know you were having fun.
Cheers.
Hi. All I can hear about it.
Yeah.
Yeah, I don't think all of them. I suppose this is Association of their.